So finally, I just wanted to finish up with some medical management of these tumors. There's a lot of high-level data here and stuff that we should be aware of. So we'll go through some of these papers. So the PROMID study, this was from 2009. This paper looked at octreotide, long-acting octreotide versus placebo. These are locally inoperable or metastatic midgut neuroendocrine tumors that are well differentiated. These were treatment-naive patients, only 85 patients, but showed a significant difference between the two groups. And just to give you an idea of which patients we're talking about here, 86% did have liver mets, although that was fairly low burden, and 74% were Octreoscan positive. So most people would say that if you're Octreoscan positive or now dotatate positive, that your tumors are going to respond better to long-term octreotide. Sort of makes sense. 66% of patients had their primary resected, and the median time to progression was 14.3 months versus 6 months. So a long-acting octreotide is approved for this indication. And then just to give you guys an idea of the overall survival curve. So this is disease-free survival. This is overall survival. Not a big difference between the two groups. So this is only 5 years out. So potentially, just like Jeff Krampus' paper, it could be that this difference in disease-free survival will translate to a difference in overall survival or disease-specific survival in a 10 or 15-year follow-up. But at the shorter follow-up, there was no difference in overall survival between the two groups. So this is another trial of a somatostatin analog for treatment of these tumors. This one was published in 2014, so a little more recent. This is lanreotide. It's a different somatostatin analog, another long-acting therapy. So this trial enrolled well and moderate differentiated neuroendocrine tumors of GI origin, grade 1 or grade 2. So that's one difference, is that in this trial, about 30% of the patients were grade 2, whereas in the previous trial, these patients were almost all grade 1. So grade 1 or grade 2, these patients, part of the inclusion criteria was somatostatin receptor scintigraphy that was positive, grade 2 plus out of 4, so that's a 0 to 4 scale. So they had to be positive on Octreoscan. Again, extended release lanreotide versus placebo. 204 patients were randomized. 2-year estimated progression-free survival was 65% versus 33%. So a similar signal. They did not report overall survival in this trial, at least in the manuscript, but showed this similar finding of improved progression-free survival. So one interesting cross-trial comparison here, the placebo group did a lot better in this trial with median progression-free survival of 18 months versus in this trial time to progression only 6 months. And part of the reason is that some of these patients had progressed prior to enrollment, whereas in the PNET trial, these patients had not progressed. So most of these patients were treatment naive without any disease progression. And I think they enrolled that niche because if patients were progressing in 2011, when this trial was probably started, they were eligible for octreotide. So they were trying to get patients before they had octreotide. So these are treatment naive patients without progression. So the two groups did a little bit better, but still it did show a signal in progression-free survival. So both these two options are available for patients who are somatostatin receptor positive. As far as which trial is preferred, there's not a lot out there. Some of it comes down to ease of administration and cost, things like that. Radiant 3 trial. So this is a trial of everolimus. So this was published in New England Journal of Medicine 2011. Again, grade 1 or grade 2 tumors. These patients had to have had progressed in the last 12 months on standard of care therapy, which in general is going to be octreotide analogs. Again, 83% are well differentiated. So these are well differentiated patients. 92% had liver mets. These patients were not surgical candidates for one reason or another. 410 patients were enrolled and randomized, everolimus versus placebo. Both did include best supportive care, which meant that they could stay on their octreotide analogs while they were on this while they were on this trial. So the RADIANT-3 trial, so this is a paper from New England Journal of Medicine 2011. So this is, again, grade 1, grade 2 patients who had progressed in the last 12 months on standard of care therapy, which in general is going to be an octreotide analog. Once again, these are a similar patient group, mostly well-differentiated tumors. Most have liver mets and are not operative candidates for one reason or another. They enrolled and randomized 410 patients to everolimus versus placebo. Both groups of note were allowed to remain on best supportive care, which meant that most of them were still getting an octreotide analog during this trial. So the overall survival did not show a difference. This is a similar theme that these patients, again, this is only at 2 years follow-up, but it takes a long time to show a difference in overall survival for these patients. So no difference in overall survival, but a significant difference in progression-free survival. So 11 months versus 4.6 months median progression-free survival between the two groups. So this trial justified approval of everolimus for metastatic PNETs. And the other thing to mention in this trial. So this is the RADIANT-3 trial. This is a trial of everolimus published in New England Journal of Medicine 2011 that led to its approval for metastatic PNETs. Similar patient population, grade 1, grade 2 tumors. These patients had progressed in the last 12 months on standard of care, which generally meant a octreotide analog. Again, most of these patients are well differentiated. Most had liver mets. 410 patients enrolled and randomized to everolimus versus placebo. Both groups were allowed to continue best supportive care, which generally meant an octreotide analog. So most of these patients, about 70%, were on an octreotide analog through this trial. So overall survival, no difference. But one key thing about this trial to keep in mind is that there was crossover allowed. So 73% of the patients in the placebo arm crossed over to open label everolimus. So this overall survival curve is a bit misleading because there's a huge crossover in this trial. But this is the progression-free survival, which shows a significant difference, 11 months versus 4.6 months progression-free survival. So this was FDA approved for metastatic disease. The one thing to note in this trial, about 20% of patients had some sort of significant toxicity, but only about 5% had to stop treatment because of toxicity. So we'll talk a little bit about toxicity of these, just because there are a lot of options in the metastatic setting. And then this is another paper from 2011, again, New England Journal of Medicine. So this is a trial of sunitinib in a very similar population to advanced, again, well-differentiated PNETs who had progression within 12 months on standard of care. 171 patients randomized sunitinib versus placebo. Again, just like the last trial, best supportive care was allowed, meaning most patients were on octreotide analogs. Progression-free survival here, 11.4 months versus 5.5 months. Trial was actually stopped early because of efficacy. So here's your progression-free survival curve. And here, no crossover was allowed, so they did show a difference in overall survival even at this short follow-up. The efficacy of these two drugs is extremely similar, and we'll talk a little bit about what to do about that. And then finally, I just wanted to talk about kind of the new thing that actually was just FDA approved in January of this year. So this is the picture, remember, from the dotatate scan. So you have a peptide, the chelator, which is the dotatate, and then a radioisotope. So we use gallium for imaging. But now instead we use a radioactive radioisotope that's going to kill cells, lutetium-177, which is now put into this chelator and bound to somatostatin, so that a somatostatin receptor is going to pull that into the cell, and then now instead of just lighting it up on a PET scan, it's actually going to kill the cells. So this is an exciting,
So the term
kind of
used for
exciting
this
new
therapy
therapy
is called peptide receptor radionucleotide
that
therapy, or
again was just FDA
PRRT.
approved
So
in
you'll hear that
January.
later.
This is the study that led to its approval. So this was just recently published in New England Journal last year in 2017. This is, again, similar group to the other trials, well-differentiated metastatic or locally advanced inoperable midgut neuroendocrine tumors. So this trial actually did not enroll any pancreatic neuroendocrine tumor patients. It was mostly ileal neuroendocrine tumors, but it led to FDA approval of pancreatic and GI neuroendocrine tumors. So this is now approved for pancreatic tumors. So these patients had all progressed on octreotide and were randomized to either the radioactive dotatate every 8 weeks plus octreotide. So again, they all stayed on octreotide versus octreotide alone. Just to give you kind of an idea, 60% of these patients had grade 4 of 4 somatostatin receptor scintigraphy score. So these patients were very highly positive on dotatate scans, and that led to think, well, dotatate therapy would probably work for them as well. So and then 30% are grade 3. So 90% are either grade 3, grade 4. So again, these patients are going to be selected in that way. So if you're very high, or if their tumors light up really well on a dotatate scan, they're probably going to benefit from this therapy. So the overall results: 20 months progression-free survival was 65 versus 11. So a pretty dramatic curve. And then they did show a difference in overall survival as well. So this, again, is another option for metastatic disease. So what does the NCCN say to do for these patients? So again, local, regionally advanced, or non-operative and metastatic tumors. So what do we do for them? It lists octreotide, lanreotide, everolimus, and then really you're going to add PRRT to this list, and you're going to have all these options. Sunitinib is not on here, but is also an option that some people use. So bottom line is you have a bunch of options. The NCCN doesn't really differentiate between them. And actually in the text of their discussion, the NCCN says, currently there are no data to support a specific sequence of regional versus systemic therapy, and no data to guide sequencing of the systemic therapy options. So we really don't have a lot of guidance about what to do with these metastatic patients. There are options out there, but not a lot of guidance about which therapy to give when. So this is something we'll talk about on Thursday night with Dr. Lee and get his input on that. So this is a slide that I took from Dr. Lee's talk. So treatments of neuroendocrine tumors with liver mets in 2017, chemotherapy potentially used for pre-op downstaging. And again, the chemotherapy options are multiple. They're listed here. Somatostatin analogs for symptom relief and indolent tumors. So probably will relieve some symptoms, but aren't going to make the tumor go away entirely, and are going to work better in well-differentiated tumors. Targeted therapies, meaning everolimus and sunitinib specifically, increasing role. There's trials ongoing as to combinations of these therapies. The toxicity of each of these therapies is fairly low, so combinations are going to be possible. And then this new PRRT, this is Dr. Lee's slide, said more investigation needed. However, again, it was recently approved by the FDA, so this is now going to be used, I think, more frequently. And then ablative therapies. So local therapies to the liver, even non-surgical local therapies to the liver. And then surgical resection, again, a multi-D approach, being selective about which patients you can resect. But clearly, when a patient is resectable, resection leads to a better survival and is worthwhile. And then one thing that's kind of coming down probably in the future is transplantation for these tumors, not done very commonly, but is now being experimented with. So we also have some data from MD Anderson that was in Dr. Lee's talk, which we'll discuss on Thursday night as well. I just wanted to mention one brief thing about the poorly differentiated tumors. Again, these are not PNETs. These are poorly differentiated stage as pancreatic cancers, but their treatment is totally different. And none of these directed therapies or PRRT are going to work for these tumors. So their treatment is similar to small cell lung cancer with chemotherapy and radiation. And that's all I have.